Yes. So she is a lady, again, 88 years old. He presented with the dyspnea in a functional class. No, the two. No. So they suffer from hypertension, dyslipidemia, hypothyroidism due to the Hashimoto's disease and chronic AF. She is also on atrial fibrillation, as I told before, but she doesn't have any other conduction disturbances like the patient, the previous patient. Regarding the blood test, some renal failure in the borderline with the 50 of urea and creatinine 1.2 for a small lady. At the echo Doppler evaluation, also done in another hospital, they found that tricuspid valve heavily calcified with an area of 0.8, with gradient of high gradient, in this case 80 as a maximum and 50 at the medium, with a Vmax of 4.5 with a normal left ventricular ejection fraction. She is not frail and she is not futile according to the heart team evaluation. Next. So following our routine practice, we did coronary angiography. The right is normal, it's a non-dominant or codominant right, and on the right side of the panel, you can observe a huge left coronary tree without significant lesions on the left main, on the LAD with some breaching in the middle segment of the LAD, very tortuous arteries, also the circ. Next. This is the left cranial and then the left caudal view, where we cannot observe any significant lesion except this breach in a not occlusive breach in the middle segment of the LAD. Next. So we did the CT evaluation. Here, the monitor is a little bit further. So the numbers are not that easy to see, but the mean diameter is 24, is 22 by 25, something like this, with a perimeter of 78, with a coronary height of 13 and 15, with you can observe there a tricuspid valve. Next. So here you can observe once again the tricuspid valve, the measurements of the annulus diameter that I already mentioned. Next. This is the LVOT 23 by 27 with the area or perimeter, excuse me, of perimeter derived of 25 with the perimeter, total perimeter of 79. So the sinus sinotubular junction is also not that big, 27, 29, and 28. Next. And here we can observe significant calcification of the leaflets. The ascending aorta is 35 as a mean diameter. Next. Here we can observe the coronary height. For the right, for the left is 12. And for the right is 16. So it's something that we have to correct. The monitor is a little bit further than in the other room. Next. And here the aortic angulation is 46, which is not significant. The next. And here the iliac axis, which is the right femoral artery, is 5.8 by 6. A little bit more tortuous than the previous case, with some calcification at the bifurcation of the common iliac artery. Next. But anyway, we had decided to go by the right femoral. This is the left, where Dr. Fava have already done the puncture and also the venous access. Next, just in case we need a pacemaker. And this is the complete iliac arteries and also the abdominal aorta evaluation. Some calcium, but not that severe. Next. And here in the angio CT, we observe also, I wouldn't say significant, but important calcification at the LVOT below the left coronary sinus. So according to the perimeter and according of the instruction for use of this valve, next, we are again in a little borderline, but we decided to go with the 29 valve. In this case, next, we decided to pre-dilate. This is these are our measurements done by us here in the lab. Here you can observe 23 by 26 with a perimeter of 78 with an area of 473 with no significant angulation. The left main is at 11 and the right coronary artery is at 14. And here we have to write, okay, perfect. The cusp overlap view overlapping the right of the left sinus at the right oblique is 8. And the caudal inclination of 30. Is that 30, correct there? 830. Okay. Next. Here you can observe some prediction according to the BTC in this left ostium, which is not that high, but is not that low to be protected. The VC, or I mean, the estimated BTC is 4.4. So I think it's still in the low risk for coronary obstruction. Next. So at the end, in the summary, is an old female, 88, with severe aortic stenosis and not fertile, with the STS score for mortality not that high, like 3, and a mortality estimated at 20. And in the heart team and discussion, they agreed that this patient would benefit from transcatheter aortic valve implantation. Next. So we have prepared this case for today. Once again, we have decided to go by femoral access. We will do a gentle pre-dilatation with only 18mm balloon. Remember that we have some calcium at the LVOT, which is not that big. And we have planned to implant an Evolut 29 TAVI after this pre-dilatation. Once again, you have observed how we reshape the wire. The loop at the tip, I always transform in an extra small. So I don't care if it is mild or small or big. All my wires become small, and then I add the second bend. I also usually do this kind of shape for the when we use the Landerquist wire, which is a stiff wire. Landerquist wire, we use it in very tortuous arteries and angulated aortas, and especially when we are using bigger valves like the 34 or something like this, where positioning is much more difficult than the 26, as you observed in the previous case, 24. Especially if you don't have significant calcifications or a patient very fragile, like the patient, once again, we did yesterday with 10% ejection fraction, significant calcification. We don't have so many chances to repositioning. It's important to have a very stiff wire to have as much less movement as you can. So this is our suggestion about the Landerquist, or when we are using Landerquist. We have the O18 balloon, el 18. Excuse me. What? Okay. Okay. Probably this patient would have tolerated perfectly at 20, but anyway, let's go gently. So, Marisa, there you can observe perfectly both paddles. The valve is properly prepared. So now vamos a ir a 180, 180. Let's on. Vamos, balloon. Let's no. Once again, let's go. Fast. Okay. Okay. Perfect. Stop. Spacing. Let's check. Once again. Okay, I think the position is okay. So Carlos is gonna hold the groin. So not that much. I will stay in the middle segment of the pigtail. We'll pull the wire a little bit. Let's, no, wait a minute. Let's reposition in the pigtail, which is torque around the valve. Now it's better. Let's zoom a little bit on zoom. It's much better. So let's test. Oh, okay. We can start now. Dr. Fava is starting. I will prevent any movements. We'll try to be at 0 or 1 or 2, not that much. Test. Be prepared for 120. Pasito. 120. Okay, Carlos, dale. Test, nada más, no. No, we are too deep. Close it. Fast. This pressure is low there, Carlos. Let's go, let's go. Let's go. Dale, dale, dale. Dale, dale, dale. Okay, let's check and allow to recover de bajar el marcapasos. Vamos a verla en la izquierda. Okay, we will try to eliminate 60.
Pon en 30.
A ver. Let me check something.
Right.
There. Sí, sí, sí. Here's his her own rhythm. Let's a little bit cranial. There. Okay, there. There we don't have too much parallax. Let's inject. I think we are too deep. We will do an additional attempt in the right position. Let's go to the right again. If we can achieve a better position. So we will 120 de vuelta, 120. Carlos, lo más rápido posible, cerrando. Perfecto. Más. Dale ahora, dale. Dale ahí. Dale todo, ahí. Now we have a better position. Yes. No, sorry, boss. Because now we have a better alignment of the delivery system. Let's go to the left. In shape. Yeah, much better. So we can retrieve the pigtail because test. The sinotubular junction is not that big. Dale, Carlitos. Despacito, sí. Inyectar. Okay. Dale. Okay, perfect. Let's remove the pigtail. We have some issues there. Now the paddle is released. No, because it was stuck on the delivery. So the peak gradient is 10, the mean is 4. Paravalvular leak is minimal. What about the depth of the valve in the long axis? Like to see. Okay, according to echo, it's a little bit higher. It's 2 millimeters. Let me check with the angio. So take retrieve your hand, orientate the monitor again because he's watching the echo perfectly. Let me see. Saca la mano, Fabián, un segundo. Let's go to the multi-images again. Let's put the angio. I think the depth is a little bit more. I think we can post dilate with the probably the 23, 24, no? Okay. Damos balón de 23. According to Angio, Fabian, the depth in the non-coronary cusp is probably 4, not 2. It's a little bit deeper than you are seeing there, because I think because you have a lot of interference with the calcium, because the non-coronary cusp is completely collapsed due to the leaflet and the calcium. That's why you cannot find exactly where is the the area of the deepest part of the sinus. Probably in the oldest day, we will leave it like this, but we will try to fix it. But we are not going to be too much aggressive for the two reasons: the LVOT calcification to prevent any conduction disturbances that now is not, it hasn't appeared. Okay, vamos a 180. Espera que caiga.
Sí.
Vamos, rápido. I will push. Dale, dale, más. Okay, desinflar. I will push the balloon to prevent any movement of the valve. Okay, only mild. According to echo, the aortic regurgitation gradient was almost non-existent, 10 and 5. By here by Ancho is 0. The diastolic pressure is more than acceptable. It's 54, 400 as systolic, with a good decret notch. Okay, let me retrieve the pigtail and do a final Ancho. And then we will close in the groin. Saca un segundito la mano, Fabi. Oh, no, seguí. I can wait. Dale. What about the circularity of the valve? It's completely circular. Perfect. Okay. So no pericardial effusion, no very good ventricular function as it was before. Let me do an Ancho. Retrieve. So, okay, this is I will do the final Ancho here. I think we have a mild play the Ancho. The mild paravalvular leak, but this is exactly in the place where we have the calcification of the LVOT. Here you can see very clearly the valve is I think it's in a very correct position. Cusp alignment is acceptable. Let's check in the working projection so we can see which is the real depth of the valve. Let's go to the 830. Okay. Let's do Ancho here. Here,
1 millimeter.
Frisalo. Probably is given the right hand to Dr. Salmo. According to this image, one more. Let's stop more. Like here. Here, you can observe probably the valve is 2 or 3 at the most in the non-coronary cusp. So we cannot go higher. So the cusp alignment is okay. We can observe how free is the left ostium. Also the perfect, filling of the right coronary artery. So both pedals are oriented perfectly in the right view. In the left view, it should be the other way around. Are you okay? You think it's okay, Marisa? Okay. Marisa from Medtronic approved. So we will retrieve the catheter. No conduction disturbances so far. We will put the Lima catheter for crossover to check the closing, put an AP view. So regarding pre and post dilatation, we belong to a team with Eberhard Grube that we did the initial experience without predilatation because we thought at the time that without predilatation, probably we would decrease the stroke rate. But unfortunately, our theory was not that true. So now we are using predilatation according to each patient. I would say that probably 60–70% of the cases we predilate because we don't like to post-dilate, especially when we're using cusp overlap view and we implant the valves at a very high position to prevent conduction disturbances. So in this situation, sometimes post-dilatation is challenging, at least. Not risky, but challenging. No, move de vuelta.